in different settings in the global south, which means Southeast Asia, Sub-Sahara, Africa, and Melanesia. Additional training has been received in development policy and project management. His long-term research deals with aging, health, and care, that is, older persons in the context of rapidly changing social, economic, and health conditions in the global south and in Switzerland. In the next 30 minutes or so, Dr. Peter will present about social determinants of health of COVID-19, lesson learned from Switzerland. So, Dr. Peter, the camera is yours.
Yes, thank you. I hope you can hear me.
Yep. Clearly.
You can see it?
Yes.
Okay, thank you so much. First of all, I thank you very much for your kind invitation. I think also many thanks goes to IBU Rector, Professor Dr. Ellen Kumar, and her representative, also Professor Gerum. Nice to meet you all again. Thank you also for Dr. Frederick Lange to introduce me. This was very kind. And of course, a very sincere thanks also to IBU Dekan, Dr. Doda. So thank you very much. And I also thank Dr. Budi Ratak and Dr. Adi Tukunan Untuk have invited me for this webinar. I think it's also a very good opportunity also to inaugurate our new memorandum of understanding between Swiss TPH and Fakultas Kesehatan Masyarakat, UNSRAT. So I think it's a very good opportunity to come for this exchange. Only one or two words also concerning Manado and Sulawesi Utara. So I have started to do my research in 1985 in Tomohon. So it's almost 40 years back, or 35 years back, when I have started to do research in the primary healthcare unit in Rumasaki Bethesda in Tomohon. And up to now, I'm still citizen in Tomohon, in Kelurahan Lansot, in Tomsel, Tomohon Selatan, Kecamatan. So, and since 1990, I'm a research fellow of UNSRAT, of different faculties. And now I also hope that our cooperation and working together with the Faculty of Public Health will be very, very fruitful. And I think one beautiful start is also this, thank you, this organizing this nice webinar. It's really time also to have this global view on COVID-19. This is not only an infectious disease in Indonesia or in Tanzania or in Brazil, but it's now worldwide, and it can hit everybody. Now, I start to save time. So I think Switzerland, it's not so far away with Great Britain, and I'm very glad that Hannah has also done this very precise introduction where also Great Britain, UK stands. On the left side, you see this very similar wave going up and going down, such as we have experienced also in Great Britain. We had this total lockdown in April, May, March, April. Then we have this new normalcy. And I would say since October, last month, we are now in a partial lockdown with a very sharp increase of this incidence rate of COVID-19. But it's since 2 weeks, it's already diminishing, decreasing, and we hope that with a new policy, which will be announced next week, we can lower it even more. Now, still, Switzerland, of course, we are not world champion in football, at least not yet, but we are world champion concerning COVID-19. This is from yesterday, concerning this 14-day cumulative number of reported COVID-19 cases per 100,000 population, though we are, yes, we are world champion with inside this green circle, we have 3 very red nation states. This is Czech Republic, it is Austria, our neighbor, and it's Switzerland. So it's on some days Czech is world champion. Yesterday, I think we were world champion. So these 3 countries, so they have this highest number of reported COVID-19 cases per 100,000. In absolute figures, you see on the left side, this is not so big, but Switzerland is maybe this is half the population of Jakarta. We have only 8 million people, but at least we are very, very hard hit. Since I would say 1 month all over the world, I think we are one of the leading, in a negative way, one of the leading countries concerning COVID. So this really hit every individual, every household, we feel it. And so these control measures, this is since 19th of October, since I would say three weeks, we have this partial lockdown. We even have a curfew, so this was like during Second World War, a curfew between 11 and 6 o'clock in the night. So bars, restaurants, all is closed, which also makes sense. And so there are these very harsh measures we have to follow. We are fined with about 300 euro per person when we don't wear a mask, for example. And on the right side, you see these posters everywhere now hanging in every street with these several measures. I only point to this poster here that we have to be very careful. First of all, also with language. We have 4 national languages in Switzerland: French, Italian, German, and Romansh. But and this is only in German. This is a failure. For example, also with migrants from Turkey, from Syria, from Somalia, so they do not understand the language. And also we have to be careful with these icons. So for example, this one with this open laptop, what does that mean? Does it mean that you have to buy a new laptop, or that you should sit the whole day before the laptop? So with icons are very culture specific to be understood. So maybe German speaking people do perfectly understand it, but people from another culture have difficulties. For example, this one, so these two persons, what does that mean? They have their mask, but is this man, is this female together? So this is tricky message also from the health social sciences. We say we have to be very careful with all these icons and messages, can be misunderstood. Next one, I turn to the social determinants of health. So this is maybe Hannah, I think you may be more familiar in London with the social determinants of health. So this SDH were, I would say 25 years ago, were developed in order to identify the most important factors which influence or which have an impact on global health or global disease. And up to now, what we dare to state is that the most important factors, determinants having an impact on health and the disease worldwide, this is number 1, this income, money again, education. So pendapatan dan pendidikan, so these 2 pen, so they are so important. And number 3 and 4, gender and social connectedness. So these 4 determinants, they are so important when we also try to identify these important reasons, causes for global health. So this is a very brief only sketch what is your understanding, so the general understanding of this SDH. Now if we go to this SDH and COVID-19, suddenly we see so many factors, so many determinants, not only income and gender, but we have housing, we have physical environment, culture, we have employment, working conditions. So it makes it so complex also to understand COVID-19 in its overall appearance, and also how we can struggle and how we can combat COVID-19. We have so many enemies within COVID-19. And this is a fully packed slide where we can identify where are these inequalities, so SDHs, so they deal with health inequalities or health inequities, these imbalances due to COVID-19. I don't read the whole slide, but there are some highlights. Income, yes. Hannah has already mentioned quite a lot. For example, healthy food. Now in this COVID-19 pandemic time, now people go for organic food. They want to have a healthy lifestyle, but this is very expensive in Switzerland. Physical exercise, I have a good income. I can afford to go for the fitness shop, but other people cannot do it. They have to go for work. We have a very sharp rise in living costs, and some people have big savings. They can easily live at home and also even going to holidays. And the affordability of home office, you have to have this digital access, all this equipment. This is very expensive. Education, this has to do also with health literacy. You have to understand all this information. What is COVID-19? What does that mean? What are the government means with these posters? You have to understand it. And this is only possible when you have more or less a good education. You have to know your risk. When you don't wear a mask, this has to be reflected. Gender, I think it's much more a burden for women. We have multiple burden for women. And also we know now from several studies, we have gendered health. So men are much more reluctant to go for medical testing, also for COVID. And much more men are hesitant concerning vaccination. And also if we have different lifestyles, also think about if you look smoking, Morocco in Indonesia, so this is a very gendered phenomenon. So this tobacco addiction, this has a direct impact on health during COVID time. Culture, it also in Switzerland, we have 4 different cultures. What is curious that in the French and Italian part, we have much higher COVID-19 incidence rate than in the German-speaking part. So this has to do also with social behavior. They like to hug and kissing themselves when they meet them. They also like to have a nice white wine. So the social interaction in different cultures is also very different, maybe more intensive, and this can be, yes, this can be fatal. And also French and Italian people, they are very critical with our government. They don't believe, they don't have any trust with or without COVID-19. They don't trust the government, whereas we in the German speaking part, so we believe what our councillors say. I think also the health and social services, everybody in Switzerland has to be insured. So it's mandatory to have a health insurance. But it depends whether you have a good health insurance or you have a cheap one. So people with a lower income have a very low quality health insurance which covers nothing. Others can go to a public hospital where you have perfect services. And we have some mountainous area in the Alps where there is no hospital. People have to drive 3 or 4 hours by car to reach the next hospital. Whereas us in Basel, we have about 10 hospitals. When I look outside, I see already 1 hospital 2 meters away. And the next one, though this is from our university hospital in Basel, the ICU, intensive care unit, you see the patient, how this runs in Switzerland, very high level, very sophisticated ICU. But also, if you look at this patient, he is very isolated in this room during several weeks. What does that mean for the patients? What does that mean for the family members when somebody is so strictly isolated and he lives on only due to medical devices? So these are the pros and cons, and I think everybody knows that, can see this is very, very costly. This is extremely sophisticated, extremely expensive medical service. Next one, last week, the Swiss government has declared that they have failed with this policy. And I'm glad that also Hannah has already introduced all these different measures. test, trace, isolate, quarantine. So this has completely failed in Switzerland. And the, for example, test, we haven't had up to now, we don't have enough test kits. Trace, the COVID-19 app has completely failed. Nobody participate, also the compliance is very zero. The isolation, nobody controls who is in isolation, who has to go to isolation and quarantine. It's a we have very contradictory information, and nobody also controls them who have to be in quarantine. So we have multiple failures in logistics, resources are not provided, information is contradictory, provision is very bad, digitalization, also bad quality, control, nothing, and the willingness of the community of us is also very low. Why is it a public health issue? So this is the next one. Why is COVID-19 also in Switzerland a problem? And I cannot read all these items. The healthcare system comes in Switzerland very quickly to the limit. These beds, we have only 1,600 beds, and now 1,200 beds are already occupied. And we are only at the beginning of this second wave. So this is one lesson learned, or another lesson learned. We have enough beds, but we don't have enough specialized staff. Specialized nurses, specialized physicians, we don't have this. We have enough beds, but this special professional health, the specialized professionals, we don't have enough. Postponement of non-COVID-19 related surgery, heart surgeries are all postponed. So we have also a higher morbidity now in Switzerland with people with, for example, heart problems. The next one is the impact on health conditions on household level. And I think one thing is very important. Domestic violence has sharply increased. We have, as Hannah said, we have physical and also mental overloading, mental stress. We have this multiple burden of women in homework. You have to be mother, wife, housewife, workforce at the same time. Men are less burdened. The health economy on household level, all these household prices have gone up, and we have less money also for health needs. There are also many people becoming jobless because their enterprises has gone bankrupt now. So we have a deceleration of economic life. We have less income, but we have higher living costs. And the next one, to understand the information. So it's health literacy. You have to have a better education when you would like to understand all this very specific and also partly scientific information. For our community, many informations were too scientific, too epidemiologist, and they couldn't understand it, what to do. And in foreign languages, so for example, the migrant communities were not reached during almost 6 months because it was not translated, all these messages in their own languages. Long-term effect, this we have to take into consideration, the life course aspect, what comes after COVID-19, the physical effects. We have now already people who already had 3 times a COVID-19 infection with up to 7 times a pneumonia. So what does it mean? But partly the mental, emotional, long-term effects, we don't know it, but in the next years, our health system will be very concerned, will be very burdened by this long-term effects. The mental health, we have particularly in the nursing homes, in the old people homes, loneliness, but also helplessness. And we have now a bigger number people with depression and the schizophrenia. We have, this is a very sad story, we have more suicide attempts of very old people, but many adolescent, particularly adolescent female people, girls, committing suicide. Dying and death, this is curious in these times. We cannot say goodbye. cannot wish farewell to people. People die in the ICU and the family members cannot approach them. So no mourning possible. This has also long-term harm for our mental conditions. The health logistics, and I think Hannah's mentioned it with these new vaccines. This is a new competition. And health policy and politics, I've already mentioned it. We have very strong federalism, very strong provinces which now are doing their own health policy, but the central government also would like to do to put their own health policy. So whose authority counts? There is a patchwork on several health policies, and we have also inequity between and within provinces. Basel-Stadt, where I live, is a very rich urban area, also with many hospitals, but we have mountainous province where we even have no hospital with only farmers. What is also this contradiction also in behavior? I think, Hannah, you have called it compliance, which is very, very right. Geneva, that is #1 all over the world with this incidence rate in the last 14 days on 100,000 inhabitants. On the left side, almost in the same road, on the left side, you see this like an astronaut, so this ambulance driver. And on the right side, in the evening, you see these people all sitting here together. Nobody has a mask, no distancing. Those is curious. On the left side, you are so cautious. On the right side, only 1 or 2 hours later in the evening, you see these young people here sitting without any preventive measure. So this is really compliance versus non-compliance. It's difficult for the government to reach these people. They don't want to comply. On the right side, so also these pictures, I think, what are these vulnerable groups? On the right side, with this picture here, this is a tragedy, and it's still going on. So this elderly woman in a nursing home, which is isolated, and there is a window. There is a window between her older daughter, so they can only speak through their mobile phones. And on the below side, impoverished people, homeless, jobless people on the right side, and now the government also starts to disseminate food for these people, because they live on the road, they live on the street, they don't have access to any health services, and they are starving almost in our roads. So I think go through this 5 headlines: vulnerable according to health and well-being status, people with disability, comorbidity, Hannah has already mentioned it, people who use drugs, who have addictions, and of course people who are also socially isolated, like this elderly lady. We have very risky, occupational workplaces. Also we have the sex workers, prostitution is going on. This is also risky business. And we have a lot of unemployed people. And of course the health professionals who share a very high risk. Children and families, not to forget younger carers who share a high risk, family members, daughters, sons who take care of an older mama. We have also asylum seekers. When you look at this minority community, we have clandestine people. We have several thousand people working illegally in Switzerland, so-called undocumented people. They don't have any health insurance. We have asylum-seeking people. And of course, stigma and exclusion. We have also people with low literacy skills. We cannot reach them with any information. Homeless people like this elderly man here. And of course, financial hardships. So I think I'm coming to almost to a certain end. I would say this is a typical health, social science, public health perspective, though these are fields which still need to be investigated. This is how about care at home in times of COVID-19, at home and in the residential nursing homes. Up to now, we don't have a good strategy. We are aware that the social relations between the generations, for example, grandchildren with grandparents, this is now eroding, and this has, this has a disastrous effect on our solidarity. Mental impairment, this will increase. End of life quality, dying and death, dying in an ICU, very isolated. This is a death without any dignity. We have to think about the concept of what is a vulnerable group, why are you vulnerable, and why not. We have so many people now resisting against all measures. What are their motivations? Why are they against also vaccines? Why do they don't want to wear masks? And as Hannah also mentioned, the trust is also eroding in our health system. Health literacy and also cultural differences, why the French-speaking part has so high incidence rates and we in the German-speaking part very low ones. Are there cultural norms?
Peter, we have 2 minutes left.
And yes, I have to have a look at my watch. And again, it's still the state of emergency now in Switzerland. On the right side, these are good news. We have such a huge wave of new solidarity. So this young lady bringing every day the lunch for this, I think this is an elderly man. So we have experienced a new wave of solidarity. But of course, also on the left side, we are in Switzerland also proud of this very sophisticated biomedical health system. This is really wonderful to have trust in this, but it also costs. And we don't know how long we can maintain this high quality biomedicine. Yes, this is looking into the future, where we also have started with UNSWAT, our own research. I think this is going beyond COVID-19, but we have to look how about these newly emerging infectious diseases. I'm a little bit afraid that we will have, every year, we will have a new emerging infectious disease based on a zoonotic transmission. So we have to look also in the ecology, how we treat this ecological balance. More and more we humans, we penetrate these areas, and these areas, this for example, tropical rainforest in Kalimantan, also in Sulawesi. So this is a rich reservoir of undetected germs, and we have this female transmitters. And on the right side, this is in my house, this is Ticus ecorbuti. So this is Enakjo. So this is really so nice, but we have to be careful. So this also bats and rats and paniki and also monkeys. So these are really important transmitters, and we know Ebola, HIV/AIDS, and SARS. So the transmitters are all these very mobile animals, and they are so tasty, particularly in Minahasa area. We have to rethink and question our current relations, human-animal, and also think about Pasar Extreme in Tomohon, so the extreme market in Tomohon. So this has to be also with animal husbandry, consumption, food, trade of wildlife, hunting, and also pets at home. We have in Switzerland, we have so many cats and rats and dogs. The urban space, what we knew now since, I would say, for the last 20 years, though the hotspots, the origins of zoonotic diseases were all in densely packed, populated, particularly East Asian cities. So we have to have a look relations and human animals, particularly in densely populated urban spaces. So this is really a hotspot, and we don't know enough about this zoonotic transmission. And the last one, whether also the Indonesian healthcare system is really prepared for these new waves. In Switzerland, we are well prepared for chronic diseases, diabetes, hypertension, and so on. But with these new infectious diseases, not yet. And yes, we have already started some years ago. I've seen Dr. Adisti is also here, Dr. Adi also. So we have already started with this unknown febrile health conditions. And of course, the tomahorn market, well known, but it's a really risky business what is going on. And the last one, it is this prospect that COVID-19 brings global health to an end. And the yes is that we have more and more health nationalism. So this therapeutic sovereignty, currently every nation, every nation state looks for itself. Every state is declaring its own policy, national guidelines, all is based on a national understanding of a nation state. We have also populism, nationalism, so it is really spreading now. And the no is that we look at the vaccines. These are global commodity. So we will have an increased global health. So there are these two understandings saying yes, because of nationalism, and other says no, it's the other way around. We are more and more globally interconnected through COVID-19. But I think what we from the global north, we also have to take into consideration, yes, what do we learn from Africa, Asia concerning COVID-19 pandemic? We look in Switzerland only into Switzerland, but we can learn a lot also from Sub-Saharan Asia, from Southeast Asia, how you tackle it, and partly in a very successful way, much more successful than Switzerland. And I think this is also the key for a new understanding also of global health. So this, I would say, this decolonizing global health, this is not something which is invented in the global north. And I think this, I'm coming to an end. Yes, Dusa. So I only mentioned this, we have, you can protect you. So we have, in Switzerland, we have even now people who protect their pets. So we have now on the streets, we have cats and dogs wearing masks. So this is a curious thing, but not to forget, we have the first 3 cases in Switzerland where human beings have infected cats. So we have their reversed case, human-animal relatedness, that human beings can infect animals. And on the right side, this is from France. It's a little bit overacting how you can protect yourself. So this lady in this very tight, sexy outfit. But this is really more than enough, I would say, wearing a mask. This is nice. But at least this is a nice picture how you really can stay healthy. So thank you very much. And yes, pakatuan mo pakalaviran, stay healthy, stay old, becoming old, and stay well. Okay, thank you so much.
All right, thank you so much, Dr. Peter, for sharing the lesson learned from Switzerland. So we have several people ask questions to both of you. So in the next section, we have a panel discussion. So there are, I will read 3 questions for both of you. First question coming from Adi Tukunan, Dr. Adi Tukunan. This is the question for Dr. Hannah. The question is, how does UK government policy protect UK people from peoples abroad came from Europe or other countries? He has 3 questions actually. The second question from Dr. Adi is, how do we know that vaccine produced by Pfizer or BioNTech could be trusted by public in UK or no conflict of interest? From Second question is also for Dr. Hannah, coming from Devika Angelika Rantung. And the question is, could you please explain more about the three-tier system in England? What are the main rules that apply under the different tiers? The third question for Dr. Peter from Angrea Ningsi Putri. She has a question about Switzerland has 4 languages and different culture in the society. Is there any fatal misunderstanding from the people for the COVID-19 preventive education poster or any other health promotion media? Okay, we restrict for 3 questions first. Now I would like to ask who comes first. Dr. Hannah, the first 2 questions.
Okay, thank you. So the first question I think was about preventing people coming into the UK with coronavirus. So at the moment we have a policy, people coming in from most countries across the world. There are a few exemptions where incidence rates are much lower, but these people have to quarantine on arrival. So that means, you know, staying at home, not going out shopping, not going out to work, and that's for 14 days. They are looking at, you know, potentially introducing testing, but this is still in the very early stages. So perhaps being tested when you arrive at the airport, or quarantining for a certain period of time, perhaps for a week, and then retesting. But that all has to be piloted to make sure that it's safe and that people aren't sort of still transmitting after that period of time, even if they test negative. So that's what we do, but it's the countries that you're coming back into the UK from, that changes all the time. So we basically have to keep an eye on the list. And the question about trust in the vaccines. So yes, there are 2 vaccines now that we have interim results for, and there are other vaccines which are in phase 3 trials, so would hope to get results in soon. How do we ensure that the people have trust in these? Well, all vaccines have to go through rigorous clinical trials, and then once they have the results, they have to be approved by the regulatory authorities. So they have to go through a number of checks before they can be licensed and given to the public. And I think it's just about putting that message across to the public that this is what we are doing. This is the standard procedure. We wouldn't be giving a vaccine that's not safe. And in terms of efficacy, those results, you know, are reviewed properly and they are made transparent. In terms of conflict of interest, I think, again, it's about people being transparent about if they have any ties or links, let's say, to the pharmaceutical companies, particularly if they work in government, and just being honest about that so that you gain public trust. With regard to the different tiers, so at the moment we don't have any tiers. We are in a complete sort of we're under national restrictions, but the government think that when we come out of these in December that we might go back into this tier system. So it's a bit complicated, and I think as Prof. Peter was saying as well, there's a lot of difficulty for people to understand these complex messages, but it was based on the incidents that you would see. So over the last week or so, what's your incidence in your area? And under the strictest tier, so this is tier 3, you would have things like people were only allowed to meet other people from outside their household outside, and that couldn't be in any like sort of restaurant gardens or anything like that. So, and most things were shut, so the restaurants were shut, I think, unless they were serving food, but there were different, or bars were shut unless they were serving food, but this were different restrictions. It went in from like tier 2 and tier 3 were quite similar, but tier 1, you were still allowed to meet people sort of within a household, but it was a limited number. but basically as you went from one tier to the other, you would have things like measures to shut certain pubs, restaurants, and it's basically to do with the number of people that you're allowed to see inside and whether they were from your household or not. But yeah, I think those would probably be revised again before we go back into that system. Hopefully that answers everything.
Okay, thank you, Dr. Hannah. I'm sorry for wrong pronunciation for tier. Tier. Yeah. All right. Then there is a question for Dr. Peter. Would you answer the question, Peter, please?
Yes, I think there are 2 or 3 questions. Yes, I think first what I see in the chat, it's I think it's this question about coming to Switzerland. Yes, you're welcome, but on your own risk. The reverse condition we have in Switzerland, that we have the highest incident rate, and we cannot leave our country, because we are not allowed to enter other countries, even our neighboring countries, Germany, France, which is only, I can see France and Germany from my own office here. We are not allowed to go there because we are the risky people. If you would like to come from Indonesia to Switzerland, no way. This is easy going, because you are from a low incident rate country. So you can, every time you can enter Switzerland. But I myself, as a Swiss inhabitant, I cannot go to anywhere, even to Indonesia. It's strictly forbidden for Swiss people to enter, because I'm coming from a high risk, or very high risk country. Say whether it is safe, I think there's also a question of your own, I would say, risk understanding. Still, we are going out, so we are not in a total lockdown. But if you observe all these measures, so Switzerland is quite very, very safe. So we don't feel threatened in every minute when we are inside or outside our homes. But for example, tourism, one of the main economic stronghold in Switzerland, has completely collapsed. So there are absolutely no tourists, particularly from Asia. They go to other countries or they stay at home. I think there is this conflicts of interest also. I think this has to do also with I think with vaccines. Yes, I think this vaccine nationalism, I think this will grow. I'm a little bit afraid. In Switzerland, we are on the safe side, because particularly here in Basel, so this is one of the center of the pharmaceutical industry, with Novartis, Hoffmann La Roche, Ciba-Geigy, Sandoz, Syngenta. So all are here in Basel. So we have a direct access to this. But for example, to vaccines from UK, from the Netherlands, from Germany, this is now really highly competitive. And I also hope for Indonesia that you get your part. But in Switzerland, at least now the newest vaccine from Moderna, I think this will be produced in the province of Wallis. So there we have direct hands on this. But there will be really harsh competition on vaccines. Not to forget that in Switzerland, when we have these vaccines, about 60% of Swiss people do hesitate, don't want to be vaccinated, 60%. So this is one of the highest rates worldwide. So people are really reluctant to go for vaccines. And this is, I think, the other question of 4 languages. We have 4 cultures, yes. The government now is now thinking about 4 different health policies. Each for each cultural region, its own policy, because a national policy has failed. So this TTIQ, this has completely failed. because we have very different modes of compliance, modes of behavior. And as also Hannah says, trust into a health system, into a government is so important today. And Francophone and Italian speaking people, they get mad with this central government in Bern, and they do their own way of life. Whether us in the Swiss German part, we are really happy that we have such strict central government rules and norms. So culture matters, I think, also in COVID. And I think you in Indonesia, with so many ethnic groups, you know how you have to tackle or how not to tackle it. It is a huge challenge to also to prepare health information according to the cultural understanding. And it starts with these symbols and icons. They can be so misinterpreted and misunderstood. Yeah, that's it.
All right, thank you, Peter. We are a little, not a little, but quite behind schedule, but I saw 3 interesting questions, 2 for Peter and 1 for Hannah, and I think we can still read this question for you. The first question for Peter, it comes from Cliff Andrich Johannes. He asked about, so this is the question. According to the data taken from Worldmeters, France is in the 4th position in the most COVID-19 cases in the world. Italy is in 9th position, and Germany is in the 3rd position. Switzerland is surrounded by these 3 countries, but Switzerland itself is ranked 33rd with the most COVID-19 cases in the world. He asked what special steps are being taken by the Swiss government so they can prevent the spread of COVID-19 virus in their country from these 3 countries. Second question for Peter comes from Zulfikar Hamid. He asked about how does Switzerland government impose COVID-19 prevention on groups with disabilities, and can this policy be implemented in the prevention of mental illness in Switzerland during COVID-19? Now, last question, interesting question for Dr. Hannah, come from Fixita Kando. The question is this: what is the UK government's approach to building public trust, especially in COVID-19? Because there are still many people who believe that COVID-19 is a conspiracy. How to make people truly believe and take prevention from COVID-19? All right. Well, I guess I'll let Dr. Peter to answer the questions first.
Yes, thank you. Yeah, I would be happy if I would have straightforward answers to these tricky questions. Yes, we are surrounded by friendly neighbors, France, Italy, Germany, but also Austria, which are all, except of Austria, which are all doing a better way. It seems so concerning the figures, but if you look on this 100,000 inhabitants measurement, so we are far in front of these 3 countries. But at least we have started earlier than France, Italy, and Germany with certain measures. So also during this relaxed summer times, June, July, August, we still had these quite harsh measures. So in October, we were already partly prepared for a new wave. And not to forget, Switzerland has 8 million people only. Germany has 82 million people. And so you have a high diversity of different people in Germany. We have different vulnerable groups, for example, also migrant groups, who shows a very high incidence rate. And I think what is also important, living here in Basel, in this tri-national area, we have a very limited mobility going to the neighboring countries. So in Basel, we are not allowed to go to France and to Germany. But we have every day we have 100,000 workers from France and Germany coming to Switzerland. So we are very restricted in our mobility. I think this is one important thing. And our neighboring countries, they still can move quite very free. And also for work, they have to come to Switzerland. And the social control, I think it's also well known in Indonesia. Social control, I think, is very strict in Switzerland. So in our apartment, we look to each other. If somebody goes out without mask, we look out of the windows and point to him, hey, you, please wear a mask. In Germany, this is quite very individualistic, where people say, wearing a mask or not, this is not your business. But here it's the solidarity also. The question about groups with disabilities and also with mental illnesses. Yes, these are highly vulnerable groups in COVID-19 times. We have underestimated. So we haven't done a good job concerning also people with disabilities, with mental disabilities, with physical disabilities. So in the new policy, I think, which will be announced next week, I think we will have new orders also how to treat more socially also people with disabilities, mental illnesses. In the first lockdown, we have locked them in. We have isolated them only in the nursing homes. They were taken out of households, and they had a much higher morbidity and mortality rate than people without disability and mental illnesses. But the last sentence, mental illnesses, I think this will be the new challenge. I think this will, the morbidity rate in, for example, bipolar depression, this will increase immensely due to COVID, to this desolidarization, to this isolation, loneliness, feeling helplessness. So this is really a new challenge, not only for the health system, but also for us as community members. And also think about elderly people. We have a new policy that no nursing home, no older pension house is allowed to close its doors, like it has happened between March and June, where so many elderly people have died because their heart, their soul was broken, not their body, but the heart was really gone away. Okay, sorry for this long answer.
Thank you so much, Peter. Dr. Hannah, the question about public trust and conspiracy theory.
Yes, thank you. It's very interesting. There have been a lot of conspiracy theories about coronavirus, but I think probably in the UK, the biggest challenge is still getting people to realize how severe COVID is, because I think unless people have seen people, family members or friends with COVID, then it's difficult for them to understand the impact. And that's probably why we're seeing, like Peter showed, people out in bars, in big groups and not wearing masks. So this needs to be addressed. What have the government done about it? Well, I think there are some messages now where they have people talking who have had their personal experience of COVID and will come on to the television, for example, and talk about it, so that it's coming a little bit more down to the community level. But I think more can be done, definitely within communities, and that comes again back to the community engagement, for people to engage with locally and say, okay, this is really what's happening, and to highlight, perhaps working with some of the social scientists, to highlight the conspiracy theories that are being circulated and how best to address those. Because even with all the best science, if people trying to change people's behavior and making them understand the seriousness of the pandemic is an ongoing challenge. Yeah, thank you.
Well, thanks very much, Dr. Hannah. So once again, thank you, Dr. Hannah, Dr. Peter, for a very nice and interesting topics and great discussion. We now will move to the second panel discussion due to time, and We now will have the speaker from Vietnam talking about controlling the COVID-19 pandemic in Vietnam, lessons from a limited resource country. It will be presented by Dr. Duong Minh Duc, PhD. He is a public health researcher and lecturer with recognized publications in reproductive health and knowledge translation and implementation science. He received his PhD in medical science from Department of Women's and Children's Health, Uppsala University, Sweden. His doctoral topic is exploring healthcare context for knowledge translation in Vietnam. Dr. Duc has been working in Hanoi University of Public Health as a researcher and lecturer since 2006. In September 2018, he was assigned as the vice head of Department of Technology and Science. For more than 10 years, he has engaged in writing and publishing many international peer-reviewed articles on maternal and neonatal health. Further, he has involved in mentoring many junior researchers on how to write and publish academic articles through related training courses. So, Dr. Duong, the camera is yours.
Yeah. Good afternoon, everybody. And thanks a lot for giving me the chance to present my topic about the lesson from the Vietnamese from Vietnam and how we have successfully controlled the outbreak of the pandemic of COVID-19 in the country. So this I will try to keep the presentation quite short. But for you who not know about Vietnam, we are the country who have a very long border with China. So when the first cases and the outbreak of the COVID-19 in Wuhan in 2019, we were very high risk country. Because we have a very long border with China, and we got the first case confirmed for COVID-19 in Vietnam from 23rd January 2020, and then despite being one of the earliest countries influenced by the pandemic, our country had received the world acclaim for a very low cost and effective strategy in the fight against COVID-19, and we quite successful because up to now we had only around 1,300 confirmed COVID-19 cases with only 335 deaths. And the average age of the infected cases in the country is 40, and it's a bit higher in the infection rate of men rather than women. And we have not recorded any new community transmission cases since September 2. So it's nearly 80 days. We don't have any new cases in the community. We only have some new cases because of the arrival coming from abroad to the country. So this is some of the update of the information, the most updated of the information about the epidemiology of COVID-19 in our country. And you can see that we got quite low number of the confirmed cases, and we did some. I'm trying to highlight what I'm saying here. We did a lot of tests to try when we found out some of the suspected cases, if they get close contact to the confirmed case and so on. So doing the test is one of the most important method in the country to control the COVID-19. But let's look at the detail, how we have controlled the COVID-19 in the country. So you can see here, we got the first case here on the 22nd or 23rd of January. But before that, in the 1st of January, when we heard about the outbreak of the new disease, the coronavirus in the country, in Wuhan, China, we have tried to do some very early measures to trying to control the COVID-19. Even at that time, we don't have any cases. You can see from the 1st of January, we have suspended a lot of flights from China to the country, even at that time. And then we also deny all the entire traveler from China to the country when we got the first case in 22nd of January. So we do very, very early measure to trying to control the disease, because we understand that we are very high risk country because we're close to China. So luckily, when we do a lot of isolation and also controlling measure, in March, we have no new cases. But from mid of March, the second wave of COVID-19 outbreak in the country started, with the new cases in Hanoi, which is the capital of the country. And the new cases was living in a very, very overcrowded area in the country. And we also found out a lot of cases that coming from one of the biggest hospitals in the country, and also in Hanoi capital. So at that time, it was quite embarrassing. And at that time, we did a lot of measures, including, you can see, on international flight suspended. We do quarantine, we do contact tracing, we did also nationwide social distancing for 2 weeks in April. And very lucky, and with a very good measure we have done so far. In May, we stopped the outbreak of second wave, and then we come to normal life for around 3 months until 22nd of July, when the third wave of outbreak coming to the country. And it was coming from the traveler abroad, coming to the central province in the country. And at that time, we had to lock down 3 provinces until we can control the problem. And with similar measure that we had done in the first and second wave, up to 2nd of September, we again successfully control the third wave of outbreak of COVID-19 in the country. So in short, the first things that make the successful prevention and control of COVID-19 in the country is we have a very good preparation with a very, very strong political commitment and prompt action, with the engagement of all of the stakeholders in the country. When we found our case, we trying to find all of the suspected case who got the close contact, and also the one who got close contact with the close contact with the confirmed case. And then we do quarantine, we do social distancing, and so on. So at that time, the supreme home of the government of Vietnam is trying to protect the public health and life, and no one is left behind during the COVID-19 pandemic. And this is some of the strategy and also the operation we have done so far to trying to control. And you can see here, we do prevention, we do early detection, isolation, case management, and also controlling further transmission. And also we're trying to do some of the on-site mobilization of resources, like human resource, like direction and command on-site, and also many transmit other. And if we transmitted too many patients, too many confirmed cases at the same time, we will got a kind of overburden for the health system. So I think that is a whole of society approach. We have done very good so far. You can see here we have the National Committee for the Prevention and Control of the COVID-19, who is chaired by one of the Vice Prime Minister of Vietnam. And we really done very well because of the Vice Prime Minister is the highest person in this National Committee, so we can collaborate all of the stakeholders, including, as I said, Army, social affair, public affair, and so on. So all of the stakeholders join. And the second lesson that why we done so far with the COVID-19 controlling, because we do a very comprehensive and credible communication So you know that we trying to do timely communication for all of the public. 2 times per day we informed about the number of new cases, number of infectious, suspected cases, and so on. And we trying to update all of the evidence based, the best evidence based information, and then transfer and then communicate it to the public. So, and we also trying to do the communication and rich communication through all of the most common and official channel, like website, like television, radio, newspaper, social media, and mobile phone message. And we also fight very good fake news and misinformation. So that keeps the public be calm when the new things happen, and the public understand that when all of the information they will get in hand very soon, and through the official channel, through our healthcare provider. So they don't believe on fake news. They don't creating any chaos or mess in the public. And the third thing is, as I said, we do a very good on surveillance, case management, contact tracing, and also large-scale health quarantine. And we even we do a lot of lockdown, even a province lockdown for 1 or 2 weeks, or even nationwide social distancing. So we do very strict method when we need to do. So that's why we can stop the COVID-19 outbreak in the country. And of course, the last thing we have to do very good suspension, and also trying to quarantine all of the arrival from abroad to the country, because it is the main sources of infection, of transmitting the disease to the local or public resident. So I think that's all about the things I want to present today. And I also have a paper writing with the same title, published in Asian Pacific Journal of Public Health with the same title. So if anyone want to read more about my presentation, you can find the paper. It is free access online. And yeah, thank you very much for listening.
Thank you, Dr. Duong. Very nice presentation about COVID-19 in Vietnam.
Hello.
Now, yes. Hello. So we now open questions directly for Dr. Duong, because Dr. Duong will need to leave soon. Okay. Is there any question for Dr. Duong? Excuse me, committee. I don't see any question I can read for Dr. Duong. Can you help me on that?
Yeah, I have stopped sharing my screen. I think that the next presenter can share his or her screen. Thank you.
Okay, all right. Thank you, Dr. Duong. I think many of the participants still, all right. Yep. Okay, Dr. Duong. There is an interesting question from Dr. Adi Tukunan. Okay, he asked that in Indonesia, government have little difficulties to manage fake news or misinformation. Does Vietnam have the same difficulties? How to control about the social media? And the second one is from Dr. Seklin Sikeon. The question is, what is the best strategies in flattening the epidemic curve of COVID-19 in your country? All right, Dr. Duong. Hello, Dr. Wong.
Dr. Prima, probably we have lost Dr. Dong.
Okay. Okay. So I think we have to move to our next presenter. Now, according to schedule, the next presenter will be Dr. Grace, but Dr. Grace, I would like to ask your permission that we will jump first to Professor Erika Ota, and then after that, Dr. Grace will present the topic. So our next presenter is Professor Erika Ota, MHS, PhD. She is a professor in St. Luke International University, Graduate School Nursing, Global Health Nursing, and a Vice Director in Cochrane Japan Center, satellite of Cochrane Pregnancy Childbirth Group, and Associate Editor of Cochrane Pregnancy and Childbirth Group. She is trained in nursing. She has a certificate of nurse midwife, a certificate of registered nurse and public health nurse, holds a Bachelor of Nursing, master's degree in health science, and also PhD in health science. Professor Erika will present about the situation of COVID-19 in Japan. So, Professor Erika.
Yes, thank you very much. Thank you very much for your introduction. I will share my slides to you. Can you see my slides?
Yes.
Okay, thank you very much. So I want to share with you for the situation of COVID-19 in Japan. And thank you very much for this opportunity. And thank you, Windy Sensei, for giving me invitation. So I want to talk about situation of COVID-19 in Japan and flowchart from symptoms to hospitalized in Japan and contact tracing in Japan and how to cope with COVID-19 in normal life. So globally, newly infected COVID-19 cases are increasing. So this is global trends up to now. So I think it's kind of the big wave is coming now globally. And especially in European countries, this green bar is Europe countries. And so now England and France are now locked down. And so after the lockdown for France, dramatically drops the newly infected cases. So lockdown is a very effective intervention, but as you know, it will be very, we need to be very patient for the normal life, and then also economically very hard to survive during the lockdown period. So we want to avoid this lockdown. And situation of COVID-19 in Japan is confirmed cases are around 12 million right now, and confirmed death is 1,800 around. And so I was so impressed that previous presentation from Dr. Dung that Vietnam is only 35 deaths cases. That's amazing. Yeah. And in Japan, actually, we have the third wave coming right now, and the newly infectious cases are very increasing right now. And the first wave we had in April, this small one, we did lockdown after April to May. And after June, because significantly dropped the newly cases, we were back to the normal life. And in the August, we had a summer vacations, so people go to travel around a little bit, and then newly cases are increased. And in September, because of the newly cases increased, the government of Tokyo Metropolitan, they didn't allow Tokyo people to go to travel outside of Tokyo. That's why it's they didn't do lockdown, but we didn't travel. So the newly infected cases were decreased. But after October, they allow Tokyo metropolitan people to go to travel domestically. And then now it's increasing, and also the winter coming. And I think the weather is a little bit dry and cold. So maybe that also affect. And now today's Tokyo infected cases is around 500 newly infected cases. And maybe in whole Japan, maybe over 1,500 around is newly infected in this today. So we had a really severe situation right now. We don't know whether we are going to lock down, or we don't know whether we should restrict the traveling, especially government giving some free discount traveling ticket. So the people can get like a 10% or 20% discount from the government support. So we can go to travel domestically. And that, but that's also, and today we just started go to restaurant discounts. So we don't know whether this kind of campaign is how much affect the newly confirmed cases in the future. And we discovered that actually a global mortality of this COVID-19 is around 2%. And actually Japan mortality cases are low, but because of the newly infected cases are around or less than 1% of the whole population. That's why the confirmed deaths are low. So we try not to infect it, try to prevent from infection. So actually my family or my friends or my co-workers, I have never heard of someone got COVID-19 yet. So because it's only less than 1% from the whole population is infected in Japan. Okay, so, and this is in April, we had a state of emergency, and then lift state of emergency in May. And okay, and different between first and second wave is that critical case decreased. Actually, confirmed cases were less than 600, around 600 in the first wave was maximum, but critical cases was larger. So the number of deaths were much more higher rates in April than right now. And for this reason, we don't know exactly, but probably I think a hospital can manage well than before. And also we have a drugs right now. And so that kind of things also affecting. And also if we get some symptom, for example, like having fever, cough, fatigue, we have a telephone consultation, or we can go to family doctor or fever consultation center in our neighbors, and they can check whether with the PCR, whether it's positive or negative for COVID-19 in the outpatient center. And if we negative, we stay at home. But if we got positive results, the center will report to the health center, and the patient goes to hospital or treatment facility. Sometimes it's assigned hotel if they don't have that much symptoms. And so what we do in the health center is we have a public health nurse. It's a national license. It's not additional to nurse. We have 2 years more master level PhD, master level license for public health nurse. And in the health center, they do like a contact tracing. So they will check the person who have a COVID-19 positive, and they will check whether they had a contact with another person in the like a family or friends or workplace within these 2 weeks. So they will trace them, and then they will also check their COVID-19 status. And even they are negative, if they have contact very closely, they need to stay home for 2 weeks without going to anywhere. So we use this kind of contact tracing prevention process until now. So sometimes it's very hard because sometimes like hospital workers, they need to stay home 2 weeks because of even they don't have a fever, but they have contacted with someone who got this COVID-19 positive. And in Japan, we made this kind of poster, and actually we translated into Indonesian language as well. And the first things we need to do prevention is washing hands, and don't put the hands to the mouth or eyes or nose. And we need to put masks and a little bit away each other. We need some distance. And also we need good sleep, eating habits, and then also exercise. And also this kind of changing air in the room is also very important things we need to do. And hand washing with hand soap and running water is the best practice to prevent for COVID-19, especially like between the fingers and nails, and also the hand wrinkles and wrists. And so we teaches people how to wash hands and children's, and it takes like 20 to 30 seconds and rinse with water. And the timing of hand hygiene is when coming home or upon arrival at workplace or before eating, cooking, or after the toilet, or etc. So we teaches these kind of things to the people. Also, we use not only hand washing, but also hand sanitizer. So now my workplace is hand sanitizer everywhere. So, but hand sanitizer, we need to use like for 20 seconds to kill the virus. So we need to push really hard, and then having a little bit more amount than usual, because it needs 20 seconds to clean using this hand sanitizer. And also moisturizing is very important to avoid drying skin. And so recently we recommend using hand cream for dry hands. And sometimes people use a face shield or mouth shield like this, but it doesn't protect than masks. So it's have a side. It can be infected through the side from the shield. So we don't recommend using this without masks. And key prevention, so home infection is pretty right now common, but prevent infection outside the home is very important. So people, we say outside the home, there are many infections at especially dinners with alcohol or in the workplace, in the lunchtime, when we take off our masks and then talk with nearby with people close to people, we need to really be very careful. Even like meals taken face to face with friends can pose a risk of infection. So mask and risks is if you don't wear mask, both people doesn't wear mask and talking closely is 90% risk transmission. And if one people have a mask and the other one doesn't, it's 30% risk. And if talking people wear mask, it's only 5% risk. And both people wear mask, 1.5% risk. But it doesn't, even both people wearing mask, they have a risk. But if you have a 6 feet, like 1.8 meter away, it's 0% risk. So we recommend people to wear mask and don't closely talking closely like this. But it's very difficult if you are going to dinner or lunch with people. If you don't, if you wear mask, you cannot eat. So it's really difficult to prevent. So this is example from Japan. In this is our university. We put sanitizers in front of the doors, and we sometimes clean desks or internet PC with alcohol. Or we also using fan and changing air and open the windows. And we try to take a distance, especially in the hospital. We try not to talk when we eat. And when we take off our masks, we try not to speak up. Yes, so actually in whole Japanese people in the train or everywhere, public places, wear mostly 99%, I think, wearing mask right now. And other example, like in the restaurant, they try to put this kind of plastic filter. And this is also like a filter to avoid. Yes. Okay, so thank you very much for listening.
Thank you,
Thank
Professor
you.
Erika. Very nice presentation. I have a number of questions for you from the participants.
Mm-hmm.
So the first question from Dr. Sekbin Siki on asking about some news report that Japan is now facing the third wave of COVID-19.
Yes.
What are the contributing factors for the third wave that brings your country to the new highest number of cases? That's the first question. The second question is from Dr. Adi Tukunan. As we know, Japan has more elderly people than many countries in the world. So how does the Japanese government handle the elderly in this pandemic area? And what positive things can Indonesian government learn to do the same thing? And the third question, this is actually the question for both Erika and Peter, from Ronald Manorekang. The question is, how do you define contact in your countries? Say if they wear mask but not eye protection, would you still define them as contact? And the second question, do you screen all inpatient for COVID? Do you think there is an element of under testing in Asia countries? All right, thank you for
Okay,
the
thank you
professional
very much. Okay, so the first one, what is the reason for the third wave? People saying that it will be the effect of go-to campaign. It's a campaign the government doing for traveling domestic, and they give us discount for the traveling. So people tend to go to traveling because we had a 2 weeks ago, we had like a 3 days national holidays. So I think people went around. I think we had like a 2 times for this kind of 3 days holiday, national holidays in this 1 month period. And also the Tokyo metropolitan people allowed to go to other prefectures right now. It started 1 month ago. So after that, people, I think from our end of October, we just started to go to travel. And then actually it's very nice season for traveling right now. In Kyoto, there's a very beautiful, leaves are red, turn into red and really beautiful. So I think the people go around traveling is most of the, I think the reason of this waves. And second one was elderly, how to prevent elderly people to get this COVID-19. And actually over 70 people, the mortality goes high, like 10% in Japan as well. I think it's globally trends, it's the same. So whole population is 2% mortality, but over 70 people are 10% mortality. So it's really high. So we are also afraid of having the trends in elderly homes, or so we try not to enter the elderly homes or hospitals. Even our hospital stopped the relatives to come to visit the patients from, I think from yesterday, I think because of the third wave, we just stopped. Only one family member can come to see the patients. So we try not to having a contact with elderly that much. And that's, but we want to learn from maybe Vietnam or other doing really well countries, how they manage it. We also, yeah, and contact tracing is not 100% working actually. So because of the number of the public health nurse is limited. So that's also affecting, and also underestimate as well. And then people try, if they have a fever but doesn't that much higher, they try not to go to hospital maybe. That's why I think the young age people are decreasing of the newly infected cases, but it's not decreasing, but I think they are trying not to go to hospital even they got the COVID-19s, because maybe they can stay home and get well. So they are out of the tracing scope. So that's also affecting this infection as well. And sorry, what was the third questions? Sorry, I cannot hear you. It's muted.
Sorry.
Sorry.
Yeah. The third question is, how do you define contact in your countries? Say if they wear mask but not eye protection, would you still define them as contact? And
Okay.
from the same person, he also asked, do you screen all inpatient for COVID? And do you think there is an element of under testing in Asia countries?
I see. So contact defines, I think they both wear masks, it's okay. But if they, one of them doesn't wear mask, or both of them doesn't wear mask, it will be contact. So we don't define the eye mask. We don't care about the eye that much, but mask will be the one of the definition of in Japan. And the last one was what was it? Sorry, could you repeat again that last question?
Do you screen all inpatient for COVID? And do you think there is an element of under testing in Asia countries,
I see.
especially Japan?
I see. We don't screen all the patients. I think if they have a symptom and they wish to go to hospital to check up, they can screen, or if they have a symptom. But if they don't have a symptom, they don't check or screen. I think in China, some city, they all screen even they don't have a symptom. But in Japan, we don't do that. Yeah, thank you very much.
Thank you. And actually, the last question also for Peter. So I repeat again, the question is, how do you define contact in your countries, in your country? And say if they wear mask but not eye protection, would you still define them as contact? And do you screen all inpatient for COVID? Peter?
Yes, important questions. Yes, testing is not mandatory in Switzerland. We have a very strict rule because we have a shortage of testing kits. So only people with 3 or 4 symptoms of COVID-19 are allowed to go for a test station. And for example, per province, we have only 1 test station. So it's a long queuing. And doctors in private clinics and pharmacies are not allowed to do tests because they seem to be not to be qualified for it. And it's, again, in Switzerland, it's a price. Who pays for testing? So this is, up to now, this is a long struggle between the health insurances and the government. A contact and also the eyes, yes, the eyes are not protected. So I think this is a very new issue also in public health and also in biomedicine. We have to take this into consideration, so the mucosa of eyes, whether this is an entry point also for this virus or not. Still, with this contact, it is now it is reduced to meter, to 1.5 meters when we go for this spatial distance. It was 2 meters, and then now with mask, it's at 1.5 meters outside with mask. And because everybody should wear a mask. So in populated, densely populated streets, we are obliged to wear masks. But if we in the evening walk alone, we usually we are not very alerted with this 2 meters distance or 1.5. So this is in meters, and it doesn't apply for family members, which is also curious.
Okay, Dr. Peter, thank you. Well, in Indonesia, maybe there are several independent organizations that develop a digital tracing app, but I don't know for sure if the government has developed their own, not as far as I know. And vaccination, there is a universal vaccination which is mandatory in our country, but not this COVID-19. I think I'm not sure how the government will do the vaccination in our country. We will still wait until I guess until early next year. Thank you. And Professor Erika, I still have 2 questions for you, but before that, I think there is one of the participants who wants to greet you. Would you please get into the screen, Dr. Windy?
Hi, Prof. Ota.
Hello.
Hello.
Thank you very much.
Thank you very much for your contribution. I think this is one of our implementation of the memorandum of understanding between St. Luke's International University of Japan and Samratulangi University.
Thank you. Thank you. I think it's Japan, right? Your picture is Japan, no?
Yeah. In our university.
Yes, he does it purposely, I guess.
Okay. Thank you.
All right. I have two more questions for Professor Rika.
Yes.
So one is from Eva Manchoro, also a Japan graduate. I want to ask Ota Sensei, because Japan has entered the third wave of COVID-19. Has the Japanese government not given any regulation? Has given any regulation not to hold nomikai? I don't know what is that, because it's useless
It's
to
drinking habit,
wear
yeah.
a mask, but people still hold nomikai. Again, I don't know. Is there any penalty for violating health regulation at the time of COVID-19? And the second one, from Emanuela Joanna Lapian, how can we help the government to handle this virus if our society has a trust issues with our own government? How can we help flattening the curve if the society was too apathetic with this pandemic? All right.
Okay, so the first one, I think today our Prime Minister said, please go to dinner with wearing masks, and if you eat, don't speak up. And if you want to speak, wear mask. So when you're eating, don't speak. So people said that's impossible. So we are now very hard time, but we understand that maybe the dinner with alcohol and also the karaoke, we sing a song, and that also with drinking will be the many cluster happens during through the drinking or dinner with family member is okay, but maybe the more than 5 people's party will be maybe difficult to do right now. So actually my hospital forbidden to go out dinner with our co-workers or other than family members. So it doesn't have any penalty for national level, but in the work place level, we cannot go to a restaurant with alcohol dinner right now. But actually in the December, Japanese people love to go to dinner because it's the end of year. So we have party in the December usually this season, but maybe it will be hard to do. So we try to do online alcohol party online without face-to-face. That we are planning to do right now. Yeah, but sorry, second one is I think it's like a more policy level.
Right. So the question was, how can we help the government to handle the virus if our society has a trust issue with our own government, and how we can help flattening the curve if the society was too apathetic with this pandemic?
Wow, that's very hard one. So it's really difficult. So I think individual level we need to do to prevent ourselves. So that's, I think, important in Japan too. I think people doesn't want to follow government sometimes, but we ourselves need to hand washing is, I think, very important. Yeah, and protection of masks and eye protection as well. Yeah, thank you.
Well, thank you so much, Professor Erika.
Thank you very
nice
much.
presentation.
Thank you.
So we now will move to the next presenter. Our next presenter, she has a variety of background. She is a medical doctor from Samratulangi University. and holds master's degree in health service management from the School of Public Health and Community Medicine, Faculty of Medicine, University of New South Wales, Sydney, Australia. And she has a Doctor of Public Health from the School of Public Health, State University of New York at Albany. Our next speaker, Dr. Grace Korompis, will present about COVID-19 infection prevention and control. So we welcome Dr. Grace.
Thank you, Dr. Bima. This is the last session, and I'd like to express my gratitude also for the distinguished speakers who have talked before me, and then all the knowledge and experience that you have shared to us. I'm amazed also with all the participants that still here, and up until now, it's almost about 3 hours since our opening. And okay. And I'm going to present about my country, which is most of participants' country, and this is about the COVID-19 infection prevention and control in Indonesia. Okay. This presentation will follow this outline, which I have planned to start with the epidemiology of the COVID-19 and also the timeline of this pandemic. And I'd like to present our responses as a nation, which also included the guidelines and some challenges. And the last part will be about the vaccine. As we have known that most of the countries in this planet have been affected by the COVID-19, and then we have now up to 55 million confirmed cases around the world and 1.3 deaths. And we can see now that China, the first country who reported the case, now have less than 90,000 cases, while the United States, unfortunately, they are the most country in terms of the number, and they have now collected about 11.6 million by yesterday. And the UK, one of our speakers have mentioned about the number 1.4 million. And our country now have been reported about almost 500,000 cases. In Vietnam, also, it's amazed that they only have 1,000 cases. The other country, Brazil, is the second in terms of the number of cases, almost 9 million cases, and followed by India, also about 9 million cases. While in the Switzerland, where Professor Peter have mentioned, it's less than 300,000 cases by yesterday. While Japan, Professor have mentioned about the number, and we can compare that my country, Indonesia, is actually the fourth countries in terms of the population, number of population, but we are now having like less than 500,000 cases. Yesterday, there were about more than 3,000 new cases have been reported, and our mortality rate right now is about 3.2%. We have now about 12.7% active cases around Indonesia, and then out of total confirmed cases, we have about 400,000 recovered. As we can see now that we are still in, we have the trend, still upward trend, And then we can say that we're still in the first phase. We were about to see the peak between September and October, but right now we can see that we have now the peak in terms of the biggest reported cases, daily reported cases, 2 days ago. National trends also show that the number of deaths and recovered, hospitalized, and also confirmed cases are still in upward trend. Reported deaths from September 21st, it's all about 100 fatalities per day, and it's still up until now. We have about 90 to more than 100 deaths per day. In terms of the sex, both male and female percentage are about the same. But for those who were reported dead, the percentage is slightly higher for male. And by age group, I think this is quite similar with other also countries, because we can see the productive age group comprise the biggest percentage of the confirmed cases. But if we see those who have the bad outcome were reported that the biggest percentage was in the age group of more than 60 years old. The clinical characteristics of patients with COVID-19 mostly similar with other reported research around the world. Cough comprise the biggest percentage, fever, difficulty breathing, tiredness, headache, and also abdominal pain, diarrhea, and also chills. The underlying medical conditions also found in our patients around Indonesia. Hypertension make up the almost half of the patients, followed by diabetic mellitus, cardiovascular, COPD, pregnancy, and also surprisingly, tuberculosis only make up about 1.5% as underlying medical conditions. Our government have put the what we call risk map since mid of this year, and the color of the map based on some indicators, we call it public health indicators. It consists of epidemiology indicators, public health surveillance, and health services indicators. Right now, this is the situation. The risk map itself updated weekly, and last week, the last time it's been updated was in November 8th, and then we can see now that most of the country is in orange or is in middle risk, while some part of the Papua is in this part of our country. They have either no cases at all or not reported. In our area, North Sulawesi, most of us are still in middle risk, while some of the Java cities, they've been reported still in high risk. This display I present now is like the routine information that have been disseminated by our national authority, National Disaster Authority, and it consists of any updated information, including the total number of cases, and also part of that is also about the situation in Indonesia compared to other countries around the world. Right now, we are in the 21st place in terms of the number of the cases, and also we can see here now that the number of PCR or rapid tests are increasing right now. And also the logistic and volunteers are also significantly increased. Now we move to the timeline of COVID-19 in Indonesia. So the first case reported in March 2nd. Before then, our government have suspended all flights to and around China from January 11, and the emergency response team have been established since January 18. The first fatality reported in March 11, and by the end of March, our government have declared the public health emergency due to the COVID-19, and then we implement the large-scale lockdown. But this, I will explain this later, because the large-scale lockdown is not like the whole country, but it's based on the region or province. By April 10, all the provinces in Indonesia, 34 provinces in Indonesia have been affected by COVID-19. By May 26, our government released what we call new normal adaptation. This is most of the communities are welcoming this new normal adaptation. But we can see that starting from this time, the number of the cases are getting more and more. By August 21st, been reported by 100 doctors have been reported deaths, and this is the time when our government established the vaccine development team, and September 3rd, and by October 4th, we have collected about 300,000 cases. The national responses in our country, ranging from the health sector to economic sector and also the education, as I mentioned before, the emergency response teams have been established, and it's followed by the release of the presidential decree in terms of establishment of the task force, national task force in COVID-19. But one of the more important things is about the financial policies. So our government have allocated amount of money, quite big in terms of our budget, about 24 billion in US dollar. And also part of the decree also mentioned about the decrease in most of the ministries budget, except for Ministry of Health and Ministry of Education. The other responses in terms of the national scale is about lockdown on a regional basis. Unfortunately, this lockdown is not fastly implemented around Indonesia. It's based on the application or request by a local administration, either governor or mayor, to Ministry of Health. But the large-scale lockdown itself must be established by the national level government. By April, we have released the national disaster, and part of the national response is our Ministry of Health have released the health guidelines for all. And this kind of health promotion have been spread around Indonesia in hope, of course, to control the number of the COVID-19 and the spread of the COVID-19 cases. So there's many type of the brochures, flyers, and many kind of languages, as you know, our countries consist of many kind of tribes and also sub-tribes. So they try to translate in local languages. Part of the health promotion or campaign is about using masks. This is mandatory if we are in the public places, but it's quite hard in our country because of the culture and because of the situation, and also because of the lack of law enforcement in most places. New normal, as I've been said before, that have been implemented, and then part of the community it's not or is reluctant by the implementation of the new normal mostly because of the spread of the cases that have not actually been under control anymore after the adaptation of new normal. We have many challenges as countries, as a nation, and also as part of the community. Most of the challenges is regard on how our health system, our capacity, including the primary health services, and also the insurance. The hygiene and sanitation before pandemic in Indonesia was a problem, and it's getting bigger and bigger in terms of population or the individuals' hygiene and sanitation. The rehabilitation services is also an issue now, right now, in terms of coping strategies for stress and all other adverse impacts of this COVID-19, because most of the population right now are facing the adverse effects of the COVID-19, either because of their direct families or also because they're friends, and also because of the information, which is the next challenge is about the information dissemination. As we know, the low media literacy is hindered the effort to disseminate the good and correct information, not only for COVID-19, but also for other health issues. The health behavior of the people itself is big challenge, and also the culture. Culture has two sides of the effect, either positive or also negative. For example, for positive one, most of the populations are religion related population, so it's quite easier to give the the health education through religion and also through these groups of people. But also in other part, culture also has a side or also disadvantages in terms of the habit of the people to accept new behavior or new custom, using masks, physical distancing, washing hands more frequent. That's part of the issue right now in Indonesia. Last part of my presentation, I would like to address about the vaccine development in Indonesia. So we are now testing 3 types of vaccines from China: Sinovac, Biotech, the Sinopharm, and also one from the UK. And we are now in phase 3 that have included almost 1,600 volunteers. And our government plans to study mass production the vaccine by the end of this year or by early 2021. But in terms of having the herd immunity, it's quite hard, and it's a really difficult issue in terms of distribution and providing vaccines for about 60% of our population. Our population right now is about 140 million. I think that's all about the situation of COVID-19 in Indonesia, our efforts in terms of the infection controls and prevention, and I hope this would be useful information for us. Thank you, Dr. Fima.
Thank you, Dr. Grace. Dr. Grace is currently a faculty member of School of Public Health, Samratulangi University, and also a consultant on Manado City COVID-19 local task force. There are a couple of questions for Dr. Grace right now. The first come actually from Dr. Peter, the other speaker. The question from Dr. Peter first, does Indonesia apply a digital tracing application on mobile phones? And the second question is, in case a new vaccine will be available in Indonesia, will vaccination be mandatory for everyone or only for particular vulnerable group? Go ahead, Dr. Grace.
All right, thank you. That's great questions coming from Professor Peter. It's nice to meeting you again through this online platform. About the digital application, I think Dr. Prima have mentioned it's currently it's under private research, so it's not like for the public sector research, and it's not have been mentioned in national level about implementation of digital application for COVID-19. I know some groups from Ministry of Communication, National Communication, have been reported about trying to provide some kind of application, but it's hindered by the budget and approval from the government. I think they now focus toward other areas right now. The second question about the new vaccine. I believe since 2 months ago, the government have planned the steps for giving the vaccine or vaccination for all, but it's in stages. So the first stage would be the health workers, those who are in the most vulnerable one. But in terms of that, they call it the health workers, and the second step will be all the those who work with the community, like teachers, lecturers, all the government staff or the public servants, and there will be several stages. But for my understanding, the vaccine itself will be mandatory for the target groups. So once the vaccine have been approved after the serial of the clinical trials, it's going to be mandatory for the target groups, as I mentioned before. Thank you.
Okay. There's not another question, but questions from another person. From Trivena Gabriela Ratak. As we know, some of the countries that are developing countries and poor in Africa. There is one country in Africa which is a conflict country that I knew and visited. The government there is not strong enough to make decisions because of many problems that occur, politics, economics, health, war, etc. Well, the question is, how do you think about dealing with things like that? She mentioned about education where schools are closed there. So it is difficult for children to get education. They cannot hope from their parents because the parents do not have a good education. And in terms of economy, the country's economy is also not good. So some of them don't have good income and some don't have income at all. In terms of health, coronavirus cases are also increasing. Knowledge and education about health is very lacking. So they do not understand correctly about diseases, pandemics, and the coronavirus. So the question is, how do you think about dealing with things like that, and how to prevent and control the pandemic based on your experiences in your country and perspective? I read the data. Indonesia got 5 best country in the world to solve this coronavirus pandemic. And actually, this question is also for all other speakers, since there are only Dr. Grace and Dr. Peter here. So after Dr. Grace, maybe I will ask also Dr. Peter to answer the same question. Go ahead, Dr. Grace.
That's a great question, very complicated one, which I believe will lead to complicated answers. But to be honest, this situation is complicated itself. So the pandemic, so the COVID-19 is not only affecting health sector, but also affected any other sectors, if it's not like all sectors of life. So your main, Ms. Rata, mentioned about one country in Africa, but the same situation, the similar condition also can be found here in Indonesia, and I believe in all other countries, even in developed countries. Education is an issue right now. Economy is also an issue globally. So from my understanding and my knowledge, which I got from other countries' experiences as well, that this pandemic have created many problems. But on the other side, we also have found that we have capacities to tackle big problem if we are facing it seriously. Mentioning about serious, since this is not individual problem, so what I learned that the differences between countries is mostly toward the government policy. So we can learn from Vietnam about how fast they make move toward the situation, and all other countries. We can see some countries in the Europe, how they tackle the problems and how they prevent more spreading. And also, I mentioned about the United States. We can see there about how I can say it's chaos because of in terms of the number of the cases. So I do believe that the government policies, so national policies in terms of getting together any elements in one nation is really important. I think that's my opinion. Over to you, maybe Professor Victor.
Yes, thank you so much. As Dr. Grace has said, huge problems we are confronting, and which won't be solved in a few weeks. COVID-19 will exacerbate, will worsen worldwide inequities and inequalities. So not only in economy and in health condition, but also in education. I think this was also the question, how about education? Yesterday we had a new research published from Switzerland and the Netherlands that children in these both countries learn 20% or 25% less in online courses than in face-to-face courses. So there is this inequity that we will lose a whole generation of young children who don't have the same chance as other children, for example, as in Indonesia, where it's still, I think also in primary school, still face-to-face. And it is important, this social contact for children, smaller or a bigger one. So we will, first of all, we will have an education inequity also in our so-called sophisticated countries like the Netherlands and Switzerland. Economy, I think in Switzerland there is now a permanent struggle between the health specialist and the economic specialist. What is more important, health or money? And I think this is also in Indonesia. I think this is an ongoing, maybe not so apparent discussion, but it is all about also money, finally, also financing the health system. In Switzerland now, the economic specialists, so they have won their struggle, so all is still open to go for work. There was still this also learning from other countries. We have admired Vietnam doing such a good job, and now I myself also admiring also Indonesia. You are much better than most. Look at the United States with this Trump government is really, yes, it's really bad. And also in Switzerland, we are shocked that such a postmodern, sophisticated country now running into this huge disease gap. And we thought we are really doing the best, but Now we are doing the worst. Finally, learning from other countries such as Vietnam or Indonesia or many African countries are doing much better jobs concerning COVID than us in Western Europe. We have to acknowledge this. We would like to have a more prominent role of WHO. WHO has a little bit lost pace. They have lost against also United States under this political pressure, but it's in Geneva, the hotspot, WHO in Geneva, though they are surrounded by COVID-19 cases. But we would like that WHO becomes a platform, a learning platform for COVID-19. Nobody in Switzerland is interested how Vietnam or Indonesia are doing it. But WHO, I think this is the master platform where all these good practices can be collected and also spread. Yeah, that's it. I mean, from my side, yeah.
Thank you, Dr. Grace. Thank you, Dr. Peter, for the answer. Thank you also for all the speakers and all the participants, especially those who post questions and participate in the discussion. Due to time, I think we have to end our discussion and also the presentation here. And I will ask the host, Dr. Angela Kalasaran, to proceed with the next program in the schedule. Thank you.
All right, thank you very much, Dr. Fema. And finally, we have reached at the end of this webinar. And I believe there are still some hanging questions from the participants that hasn't been answered from the speakers. So probably, for example, I think there are still a few questions for Professor Peter. If you don't mind, is it okay if we emailed it to you and maybe you can answer it, and then later we will pass it on to the participants?
Yes, no problem.
Okay, great. Thank you very much. All right, so we'll try our best to send all the unanswered questions to the speakers via email, and then after we got the response back, we will pass it on to you to your email, or also you can check on the YouTube channel where there will be some descriptions at the bottom, and we will put the unanswered questions there and the answers, so you can check it out on the YouTube channel. So again, I would, on behalf of the webinar committee and the big family of Faculty of Public Health, Samratulangi University, I would like to give our biggest appreciations and thank you for all the speakers of this webinar, Dr. Hannah Brundle, Professor Peter van Uwijk, Mr. Dol Menduk, Professor Erika Ota, and Dr. Grace Krompis, and also to our moderator, Dr. Frederick Lange, our Dean, Dr. Fanda Doda, and of course, all the participants from all over Indonesia. We have participants from Jakarta, Gresik, Bandung, Semarang, Bogor, Jambi, Batam, Tahuna, and of course from Manado. Thank you very much for joining our webinar, and hope to see you again in another event, another time, hopefully face-to-face, not only from online through Zoom. So yeah, hope to see you again next time. So everyone, wear your mask when you go out, wash your hands, and stay safe, everyone. Bye-bye. Good night.